Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative. And for those who may not know the PCC, we are a national, nonpartisan nonprofit that unifies very diverse voices to advocate for better health and well-being for all Americans by strengthening primary care. I'm so pleased today to welcome you to a discussion about addressing the impact of H.R. 1 Medicaid changes on primary care. As many of you know, in July of 2025, Congress passed new legislation, H.R. 1, and it has many other names, but for today's conversation, we're just going to refer to it as H.R. 1, which made major changes to the Medicaid program. There are increased restrictions on eligibility and financing that are now phasing in. And these are affecting state Medicaid programs, beneficiaries, and primary care practices who are navigating both administrative and fiscal challenges that sustain and deliver primary care for those who rely on Medicaid and CHIP across our country. That's why today's conversation is so vital. The perspectives of today's guests will bring very important insights into how primary care can work with their Medicaid patients to navigate this new environment. Just a few housekeeping items before we get started. This session, like all PCC webinars, is being recorded. The recording and slides will be posted on our website, thepcc.org, within 48 hours. You can find this session and all of our webinars on our website. We'll also be taking questions from you all using Zoom's Q&A tool, which usually you can find at the bottom of the screen. Panelists will answer those questions at the end of the webinar, but please feel free to put them into the Q&A tool as they occur to you. Chat has been disabled for viewers, but our team will be providing links to relevant resources throughout the webinar, so take a look for that. Also, and finally, the PCC is very committed to delivering high-quality webinars and exploring topics that are important to our community. We'd appreciate if you took a moment after the webinar is over to fill out the post-webinar survey, which you will get in your email, so that we can get your ideas about future programming and also get your assessment of this webinar. With that, I'd like to introduce today's moderator, Dr. Brandon Wilson. He currently serves as the strategic advisor to the CEO and also as interim state and community program lead at Community Catalyst. Previously, he served as co-interim CEO and president of the organization, guiding strategic efforts to build a more equitable health system rooted in community leadership and perspective. Brandon is also on PCC's board of directors. So pleased to welcome you as moderator, and let me turn it over to you, Brandon.
Thank you, Ann. Thank you, PCC. Thank you, everyone, for joining. It's certainly my pleasure to moderate today's conversation. I think having worked both in federal policy as well as delivery models, and now alongside patients and advocates, I can say I'm certainly aware of how and when and how quickly policy, at least the intent of it, as well as lived experience of people can actually diverge. One thing I'd like to name up front is that many states are still operating with some incomplete information. And that uncertainty itself is, I think, is shaping decisions in very real time. So I want to keep that in mind as I introduce our panelists and we had the discussion today. First, I'd like to introduce Perry Briskin. Perry is the Deputy Secretary for Healthcare Finance and Delivery in the state of Maryland for Medicaid, where she oversees the state's $14.6 billion health coverage program, which serves 1.5 million residents who live in Maryland. In this role, she leads policy, operations, as well as financing across the state's largest public program. Thank you, Perry. Next is Dr. Sandy Chung, and Sandy has held over 35 state and national leadership positions, including national president for the American Academy of Pediatrics, and she is currently CEO of Trusted Doctors, which is a pediatric practice of over 300 clinicians in Virginia, Maryland, as well as DC, and president of Trusted Doctors Alliance. Thank you, Sandy, for joining. And last, I'd like to introduce Ann Jensen. Ann serves as the administrator for Nevada Medicaid. In this role, Ann oversees the provision of medical, behavioral health, pharmacy, as well as dental coverage for nearly 800,000 residents of Nevada, which is an annual cost of about $15 billion. So thank you all for joining. Cannot wait to jump in and get your wonderful expertise in these areas as we're trying to figure it all out. So we're going to jump right in with the first question. And for order, let's see, Ann, Perry, and then Sandy, if you'd respond. But first question is, so we can level set for the audience. What effect do you anticipate HR 1 will have on primary care delivery and access overall?
Good morning, everyone, or good afternoon for those not in Pacific time. It's lovely to be here. Thank you for having me. I will note, this wasn't in my bio, but primary care is very near and dear to my heart. I spent 5 years working with independent primary care physicians and FQHCs to help them be successful in value-based models. And so bringing that lens to my work here in Nevada, and really passionate about all the work that this group is doing to ensure folks have access to really a primary care home to navigate their care. I think that primary care home and kind of trusted voice is going to be incredibly valuable as we navigate this changing landscape in the months and years ahead. I'll give a little context in Nevada. 1 in 4 people in our state receive health coverage through our Medicaid program. Of that 800,000 people, it's about 200,000 that fall into the adults within the expansion population. Of that, I think of it as kind of a funnel. It's narrowed a little bit further to those that are directly impacted by the eligibility changes that are coming beginning this fall and winter and into next year. So I think what's really crucial on our end, as we talk about impacts of HR 1 in our state, those are primarily felt by a very particular group of Medicaid recipients. Those are important members that we want to communicate very clearly with, but I'm always wary of how do we communicate in a very targeted manner to avoid more confusion or concern from our broader population. The way our Nevada Medicaid program is designed, the financial impacts of HR 1 are not felt as directly by patients and will not be felt for at least 2 or 3 more years because of the design of some of our tax funding mechanisms. I'm grateful for that design, which is, of course, not something that we anticipated ahead of time, but I think what's really key is the eligibility pieces are going to be felt first, and now is the time to really be communicating as clearly as possible about what that looks like. We expect about 120,000 people will have to submit some sort of documentation to maintain their Medicaid eligibility. And so we're beginning those patient communications now. I'm happy to talk a little bit more about what our process will look like, particularly with our FQHC partners who are very close to our kind of strategy in this work. But I'll note that there will be changes and there will be coverage loss. And I think that's not what any of us want. So everything that we're doing is to help ensure members and providers are informed about what's changing and what options they have to navigate that.
Thank you, Ann. Really quick follow-up question. So where states are listed, particularly Nevada, are actually feeling the pressure even before full implementation?
Yeah, I think for us, it's the complexity of the tech and IT side, which is perhaps maybe the least sexy part of this work, but it's incredibly complex. I'll note we received approval to do a really complex IT modernization project well before HR 1 was passed, and that's to move our Medicaid eligibility process to our exchange and have that be the single point where folks can access health coverage options across our state. And I'll talk more about that and how we're leveraging our providers through that process, but I'll note we're having to build our work requirements components in our old system and in our new system at the same time, and with changing and ever evolving guidance. So I think what we're feeling right now is just the time and resources really needed to ensure that what we're building is done in the most efficient manner with I'll note very limited general fund and state dollars. Nevada doesn't have an income tax, so we're operating pretty lean. And so how do we do that in the IT space as creatively and efficiently as possible?
Thank you. I appreciate that. Harry?
Thanks, Brandon, and good afternoon, everyone. I echo everything Ann said. So similarly, I think Maryland's just a little bit bigger, but everything Ann said, the ratios all work out the same. So we're 320,000 adults who are in the Affordable Care Act adult group who will be impacted by these changes. We've estimated as many as 115,000 of those could lose coverage. And so what that means for primary care is just increase in uncompensated care. We also know that we estimate about 15,000 people with certain immigration status will be kicked out of coverage 100%. And so there's no pathway for them, at least through Medicaid. And so, yes, number one, we're worried about uncompensated care. I think where we have been focused on, which is many states, is implementing the very challenging IT pieces that Ann mentioned, and we are looking at all ways that we can increase automation because we know when people are auto-renewed that they are less likely to churn out of coverage. So we are very focused on keeping all Marylanders covered with tech and data sharing first. And then we also are working on, not dissimilar to unwinding, a full rollout of comms material so that people know what changes are coming, providers can educate their patients. There are things that Maryland started during unwinding to make sure that providers know who on their panels are up for renewal. So we are doing all of that work as well. I think Maryland is a little unique in that we have a large Medicare and Medicaid advanced primary care program, one of, if not the largest in the country. And so we already for years have been giving enhanced payments to our primary care providers and trying to drive that change in our state. I think we are looking and very open to additional ideas for how do we strengthen primary care in Maryland. I think just as Ann said, the fact that we have to implement HR 1, it just takes up a lot of oxygen in the room. We can't do as many innovative things that we would do otherwise if HR 1 wasn't happening. So we're very focused on how do we implement HR 1? How do we do it so we're both meeting federal requirements and keeping people as covered as much as possible, because that's what's going to be the main thing is keeping people who are eligible in coverage and making that as easy for them and for our staff as possible.
Thank you, Barry. And I almost want to pause on something that you said. And it's really that these things are often framed as, let's say, administrative changes. But in reality, what we're talking about are clinical consequences. And one can see them, of course, as eligibility rules, but it's also increasing churn. Like this is also shifting administrative burden. And frankly, it can destabilize access, taking away that primary care end up having to absorb first. So thank you. I really appreciate hearing what the impact is and how Maryland is mitigating those. Sandy, would love to hear your perspective.
Yes, thank you all so much for having me here. I think what I'm bringing to this conversation is really the practice perspective. Even though I'm a pediatrician, I also work with several adult medicine practices in our IPA and our clinically integrated networks. And what we're finding is that across our practices already, even though many of the changes haven't been implemented yet, families are already confused, patients are already confused, and they're worried. They're worried about losing coverage. If they've already lost coverage, they're not able to afford the alternatives. So whether that be the exchange or private insurance, they aren't able to afford that. And so when the adults they cannot afford the care, then ultimately the family doesn't receive care typically, because there's just, again, confusion that if an adult loses coverage, it doesn't mean that the child loses coverage also. We saw this very much when unwinding occurred, where families just weren't coming to seek care. Even in, yeah, let's see, we're in March, end of March now. So even in the first 3 months of 2026, we've seen a dramatic reduction in volume in our clinics already. And the practices that have a higher percentage of Medicaid patients are seeing that more than those who have lower percentages of Medicaid patients. So I think the impact, despite the fact that we know there's much more coming, just that recognition that whether it's HR1, whether it's just the general economy, whether it's general fear of financial situations, people are already changing their behavior for seeking healthcare. And ultimately, your practices are the ones who may feel that the quickest. We're almost the canary in the coal mine, if you will, because the margins are so small in primary care already that when there's a change, it really impacts our ability to function. In fact, I've seen already, 8 practices I'm located in the Washington, D.C. metro area. So Washington, D.C., Virginia, Maryland, in our cohort of pediatric practices across those regions and states, we've already seen 8 practices close down just in the last few months. And this is a metropolitan region, not to mention what's happening in rural communities and places where access to care is already a problem, access to primary care is already a problem. So when we have changes to Medicaid, which for children is a major payer, 40% of children, or if not more, are covered by Medicaid. So that means your pediatricians are disproportionately impacted by changes, even though the changes technically are happening to adults, and we can talk about that more later. But I think just understanding that the primary care infrastructure is already very fragile, and any change really can cause catastrophic events to a practice. And so I think I wanted to point that out.
Well, thank you for that. And we will talk about some of that later, but I want to stay right there for 1 second. Just thank you for almost spelling out and illustrating for us what the impact is directly for practices as well as patients. But one or 2 changes that we've probably heard a lot of conversation around is the more frequent redeterminations, as well as the work or community engagement requirements. What does that change do at the very practice and patient level, from your experience, or what you all are planning for?
Yeah, I think we as clinicians need the information too. Unless you're very much in the weeds and learning about what's happening in HR1, your average primary care clinician is not focused on this. And in many cases, insurance issues are not front of mind when you're trying to take care of a patient right in front of you who has a clinical need. And so being able to have that awareness at the primary care clinician level, at all points of connection with the patient. So your front staff, your nursing staff, your clinicians, your billing teams, all of those people need to be aware of what's happening and what is that direct impact and what does it mean to show, the community engagement piece. Like when patients are asking us, what do I need to do? How do we have the answers? And right now, I don't think we do. And so I think that community engagement, particularly, how do they, do the redetermination? And again, I just sort of look back to when that happened over Medicaid unwinding. So many people lost coverage because we just couldn't reach them, or they didn't understand, or it was, administrative things, hurdles that got in the way. And so early on, as much as we're able to engage the clinics in the awareness campaign, the better, because we're seeing these patients every day, and they may just be coming in for a visit once a year for their annual well visit. So we have one opportunity to provide that information when they're in our clinic. So it is important to do that early.
Yeah, thank you for that. And what I can say, certainly from our experiences, from working directly with communities, as well as with beneficiaries, what we hear consistently is that complexity itself can become a barrier, even when folks are eligible. And so from the patient side, I would say even simpler systems, they still fail if they assume that time stability, let's say broadband or trust are things that are there. So I appreciate how this will certainly impact people in their direct lived experiences. I'd like to move on to the next question and start with Anne and then Perry and then Sandy. Given these pressures that you all have mentioned, how are states and even practices reacting to protect or even bolster primary care in this very moment?
Yeah, I appreciate that question, and I feel like there's always more we can do. So I also welcome feedback from our group and Sandy as a provider as well, if there's things that you've seen be really helpful. I think first thing we're focused on is be incredibly clear in all of our communications to our members and to our providers about what is changing, what isn't, and how we can use their support. Right now, our messaging is entirely help make sure that your contact information is up to date. So that way, when we reach out to you with any information that we need, we're making sure we get a hold of you. I recognize that's an incredibly complicated thing for a lot of our patients, right? Their contact information changes on a very regular basis. And so our primary care providers, as a really trusted entity that is seeing our patients in person, is a really key resource to help us do that. I think the second piece we're really focused on, given the budget challenges and constraints that we're all navigating both at a state and federal level, we need to get creative about how we pay for healthcare in our state. And so we're really focused on implementing value-based care initiatives in partnership with our managed care organizations that help really reward our high-performing primary care groups. I recognize there's a lot of complexity to some of these initiatives, and so to make that easier for our providers, what we're doing is we're creating state guidelines and models that our MCOs are then using to contract with providers that have a very narrow set of core measures that every MCO must use. So that way providers aren't facing a host of different quality measures. I was talking to one of our FQHC leaders recently who's an excellent value-based care lead, and they shared with me that they have 87 quality measures that are being incentivized in some way, which I think is a standard example of what our providers are facing. And so thinking about how do we quiet the noise and limit some of the administrative complexity of receiving value-based payment in our state. I'll note we're really focused right now on maternity care and thinking about how primary care is a crucial component of that continuum of services and piloting some models with our FQs as we do that. So, that takes us down a little bit of a different rabbit hole, but I think it's something that I'm really proud of. And I think is something that every state will continue to look for as creative ways to make each and every one of our state dollars stretch a little bit farther and also reward the outcomes that our providers are working so hard to achieve.
Excellent. And also given that the constraints as well as complexity that you mentioned, are there, let's say, any new or emerging trade-offs that you're seeing?
It's a good question. I have the benefit of a biannual legislative cycle, meaning every other year. So we haven't had a budget build or a legislative process come since HR 1 has been passed. Like I mentioned, the financial impact on our state because of the way our program is designed doesn't hit until a little bit later and primarily is felt in terms of supplemental payments to hospitals. So we haven't had, candidly, to make many trade-off decisions at this point. I think it's more so being very thoughtful and reflective as we plan for the future and making sure that the rate increases we're committing to or the new benefits or the waivers we're pursuing are all things that are very well aligned with the core functions of our program that we will be sustaining long term.
Yeah, thank you. Perry?
So I think it's not dissimilar from unwinding. We're all dusting off our unwinding playbook here. So we are just doing a lot of meetings with our associations. So if you are on this call and in Maryland, make sure you're in touch with your respective associations that we meet regularly with. So we're trying to keep everyone posted, internally in the state on our progress towards implementation. I think having communication materials that both speak to the people directly impacted and who are going to have to doing something different, but to Sandy's point, making sure that we have materials for even if you aren't directly impacted, so there isn't a chilling effect, or we can mitigate the chilling effect so people don't just stand down. And I think we already have this advanced primary care program, which we are continuing to support our providers in. And that's just another way that we stay in close touch with our providers and reward providers based on quality. But also we're going to be needing to hear from the eyes and ears on the ground. If things are going really poorly, we'll hopefully see it in the data relatively quickly. But I think one thing that we've been trying to look at these changes coming from this new legislation, this new law, is that there's no end date to this. This is going to be with us for some time. And so we think about this as a phased approach. So what is happening February 2027, we need input so we can course correct for late 2027 and 2028. And so I do think, like with any new initiative, there's a transition period, but this is a marathon, not a sprint. And it's not even a marathon because marathons have ends. This is no end. Currently, we are with work requirements forever. We are with 6-month redeterminations forever. And so we're just going to have to get used to a new reality. And I think it will be really important that there is two-way communication between the state and our primary care providers to understand what can we do differently within, the bounds of federal requirements, and where you all need support. If things aren't going well, raise the red flag on uncompensated care. It depends on your state whether Medicaid is responsible for funding that uncompensated care. In Maryland, we aren't as much. But we have other entities that do that because of we have a unique model in Maryland, our all payer rate model. So I think that will be what I see as important, is just staying in really close touch and making sure that we are nimble enough to respond to different asks, because we're all entering an unknown. Maryland's never implemented work requirements before. We've never had 6-month redeterminations before. So we just sort of have to stick together and be open and responsive to everyone's feedback.
Okay. So with that, and really appreciate that you all trying to listen to the real impact on the ground. Are there any things that you're hearing now that's probably most frequently misunderstood or even under or overestimated as we're thinking about how to implement some of these requirements?
I'll go first since I have the floor. I mean, I think it's what maybe Anne said, was just like we are hearing there is confusion. This stuff is complicated, and Sandy maybe alluded to it too, is like people who are not subject to the work requirements think their Medicaid is being cut. There'll be a change to Medicaid completely unrelated to HR1, and they're like, oh, is this because of the new federal administration? And so Medicaid is complicated and always evolving. It just happens to be that HR1 and this new law is a particularly big change in Medicaid. So I think it's just, that is what we're seeing. I don't think we're seeing it in the numbers yet. I don't think it's like people are not redetermining their coverage. I don't think, at least in Maryland, we are not seeing uninsured rates preemptively going up. We are not seeing that, but we are just hearing, whether it's through our call centers, our providers, our MCOs, just general confusion, which we hope our consumer education campaign that we are launching one in Maryland starting in May, that will help to give people more information and more materials to combat that misinformation. But that is what we're seeing, is misinformation, and then a lot of very understandable concern from providers, big and small, about looming uncompensated care rates. And what does that mean, and when those are going to hit, and how they're gonna manage it.
Yeah, thank you. And I'm gonna move to you, Sandy. Would love to hear your thoughts.
Yes, thank you. So, I want to follow on with about the uncompensated care portion of this. I think often when we're thinking about uncompensated care, the hospitals are probably the loudest voice around that space. But when we're thinking about primary care, largely the care is outside of the hospital walls. And whether or not they're part of a health system or not, or they're independent, or they're part of another group, where they're not related to hospital payment in some way, I think the large majority of primary care sits in that space. And so, if that's the case, what is the mechanism to ensure that primary care doesn't fail because they are now providing uncompensated care also? And sometimes that uncompensated care, and this happened to us a lot in the unwinding phase, we didn't know the patient had fallen off the rosters of Medicaid. The family didn't know. There was a child who was given a prescription, the parent was given a prescription for the child. It wasn't until the parent went to the pharmacy to fill the prescription that they learned they were no longer in Medicaid. By that point, the doctor's visit was done. We had already given the delivery of care. We had done all of that. Are there mechanisms in place where you could have figured that out in advance? Probably, in many cases. But if you don't have the infrastructure, if you're a one or two doctor practice or one doctor practice, and you don't have a team that's running eligibility on all your patients, so there's a lot of this infrastructure requirement to try to catch when a patient might be falling off of Medicaid or doesn't qualify anymore. And that sometimes it's too late. You've already taken care of the patient. And once you've done that, is there a mechanism for primary care to receive payment from the previous MCO, for a visit or two, those types of things to give us a little bit of wiggle room so that we can manage to take care of people still while they're in our offices, and then help them then do what they need to do to hopefully become re-eligible, or re-enroll. So there's that. The other thing that's happened though is because the anticipated Medicaid reduction in budgets all across, the country, and people are no longer doing things that are new. So hospitals are not growing programs. They're trying to figure out, how do I reduce staff? How do I reduce programming? We're no longer innovating. We're no longer looking for new programming. We just had our General Assembly session in Virginia, and very clearly from day one, they're like, we're projecting this level of shortfall. There will be no Medicaid increases. There will be no anything. There will be no new pilots, and it was just really that chilling effect of innovation and the ability to continue to grow and figure out new ways to support primary care, because we still need primary care. And regardless of what happens in the payer space, primary care is essential to the population health of our country. And so how do we continue to elevate that and continue to move that forward in this landscape of the situation we're in today? So continuing, again, if you're going to make a change, can we prioritize primary care and that sort of concept of how they provide the best return on investment, right? How do primary care does that long term? We all know that. So how do we continue to make sure that doesn't get lost as we try to adapt to the new climate that we're in?
Thank you. You've said a lot. So one, I heard almost a retreat in areas of innovation, some increases in status quo, all within a container of some infrastructure challenges. So given that, let's name it. What are some areas that or where do we draw the line of maybe some things that we really need to protect versus areas that need to really be redesigned? Have you begun to put some thought into that?
So I'll admit I'm 100% biased, but we should protect the children. So as a pediatrician, obviously we know that investment in early childhood brain development, and early development pays dividends in a person's life forever going forward. So how do we ensure that, because Medicaid is the largest payer of child health care in our country. So when we're having changes to Medicaid, which affect the adults, how do we ensure that the children are not the ones disproportionately impacted? And so continuing to make sure that, so the basic coverage, dental, developmental screening, behavioral health, all the things that we know kids need stays protected. Because if you have a budget that you need to keep, neutral at the state level, it needs to be balanced, and you've got all these adults that you need to take care of. How do you do that without taking away from the children? And so again, how do we continue to make sure that our children are protected and covered, that families, when the adults perhaps are no longer eligible, understand that their children are still eligible, continuing to lift that up in front of folks, because otherwise the whole, society pays in the long run. So I think it's really important we continue to shine a light in that space.
Thank you. And since you mentioned innovations, I'm going to turn to you, Harry. Maryland, of course, has been working across payers to try to strengthen primary care through MD-PCP as well as the HEAD model. How are these models helping? Are they being tested by HR1's changes?
Yeah, absolutely. So in Maryland, for 7 going on 8 years, we have had an advanced primary care model where we give enhanced payments to, up until late last year, just Medicare providers, Medicare primary care providers, and then we expanded it to Medicaid in middle of last year. And so it's been an important program, and that has shown results, shown savings for the state. It has shown reductions in some key performance, key quality measures that we look closely at. I think where HR1 intersects with this is these payments to primary care providers are connected to coverage. And so you get payments towards, how many people enrolled in a program. And so if the people enrolled in Medicaid go down because of churn, then your payments go down. I will also say, just more broadly, we are also, our AHEAD agreement is going through changes. And so the AHEAD primary care program is also likely to go through some changes starting in 2028. And so it's not just HR1, but it's a new federal administration that is putting different types of pressures on different parts of our healthcare system, and specifically on the Medicaid program. So I'll say on the flip side, there is the Rural Healthcare Fund, which every state received about $50 billion over 5 years, spread out across all 50 states. And each state had the flexibility to put forward a proposal for how to spend their rural healthcare dollars. And in the state of Maryland, some of those dollars are going to our primary care clinics. And similarly, in sort of grant dollar kind of payments to rural primary care providers. There is, quality payments. It's sort of like an expansion of our advanced primary care, but just for rural healthcare providers. So sort of investment dollars into those rural practices. So I think there are lots of ways that Maryland is continuing to invest in primary care, but certainly the Medicaid changes under HR1 could put that in jeopardy because of the way our primary care payments are structured, which is number of individuals enrolled in Medicaid, number of individuals enrolled in Medicare. And so if the Medicaid numbers go down, the payments go down.
Mm-hmm. Thank you. And I'm going to turn to you, Anne. One that's discussed as a piece of HR1 is the push to streamline how community engagement requirements are being implemented. How is Nevada approaching that?
I appreciate the question, Brandon, and would love to maybe take an even broader angle on it to talk about how do we make Medicaid eligibility as a process be viewed very clearly as a coverage program, right? Medicaid is a health coverage program, just as a program on the exchange or a state employee benefits program like I'm on, or an employer-based plan. And so I think what we're really focused on in Nevada is ensuring that as we educate people on health insurance, which is an incredibly complicated process, that we talk about health coverage as a range of options that you may be eligible for a variety of reasons, and can select the option that works best for you, right? And so that is a big shift in our state, and something that we've been working on for a long time. Like I mentioned, moving everything to the exchange is a really big step forward. It provides a real-time online determination process where people can submit pay stubs or identity verification or work requirements verification materials to that web platform and do that in real time. What I'm really excited for, and I know our primary care association is as well, we're developing what we call a community partner portal as part of that website, where a navigator at an FQHC who encounters someone who may be eligible for Medicaid or another insurance option and isn't quite sure can log on to that portal and sit side by side with someone and kind of walk through those questions. And so I think as we think about community engagement requirements, what we're really focused on, of course, use all the data we have access to right now to avoid asking for further information from patients. But really fundamentally, to talk about Medicaid as one of many coverage options. I'm biased. I think it's an excellent option, and it's low cost and no cost for almost all of our recipients. But we want folks to be really informed about what those options are, because we think actually in Nevada, there's more people that are eligible for Medicaid but aren't enrolled. And that's a huge opportunity for us to be focused on. And working and supporting those folks through the community engagement verification process will be a key part of that work. So I hope that's helpful. I know it's a little bit broader than your question, but it's work we're really proud of. It's ongoing. Our website launches in September, and we'll scale from there. But I think it's a really key step for us to try to ensure that as many people as possible have coverage in our state.
No, and I really appreciate the framing and the offering of some narrative change that I think we could all use in this moment. So thank you. Sadie, going to come back to you.
Yeah, go ahead.
Oh, I have a specific question for you, if it's okay.
Yes. Oh, sure. Go ahead.
Yeah. So we've, or you've seen at least from both the practice as well as policy side, when adult coverage changes, what does that actually mean for children's access to primary care?
Yeah, so similar to, if you have private insurance or you're on the exchange, often people are thinking about enrolling their family into something. And so if you as an adult don't have coverage, then your children also will not have coverage. And that's a fairly common framework that our healthcare system works under. In Medicaid, obviously, that can be very different and should be different for partly because of how Medicaid evolved, right? As for Medicaid and CHIP, the idea was let's help children and let's help the elderly disabled populations primarily, and those who are low income, right? And so, but since we've expanded it, then adults who are now enrolled with their children may not understand that if they no longer are eligible or they didn't do the requirements to be eligible or for some reason they don't qualify, that does not mean their children can't have coverage. And that communication is so essential here. Also, when we're talking about the community engagement requirements, that's sort of a new idea for everybody. And so how do we explain that? Who does not need to do that? If you're a parent of a young child, you do not need to do that potentially, right? So there are exceptions, and when there are exceptions, there's complexity. And how do we help families navigate? You mentioned FQHCs and often there are resources available at places that are set up to handle Medicaid and enrollment and have care navigators and so forth. But if we kind of pivot back to primary care independent practices, or smaller practices, they are not set up for that. When Medicaid is 20% of your population or 30% of your population, it's still children, it's still families, it's still care you're providing people, but you don't have an infrastructure set up for a practice that might have 90% Medicaid, for example. And so when we're thinking about how do we help those entities do this work and not make it an unfunded mandate for them to help families navigate this complex insurance space, and there are ways, right? Give us the phone numbers we need to give families, give us the websites that we need to send them to. Obviously it's not ideal. We'd rather have a warm handoff. If there's a way for us to send you a list of all the patients who you need to reach out to as an agency, then maybe that's the way we do this. So I think working closely with your primary care clinicians in your state, figuring out what they think they need or what they can work with or how they can adapt to whatever workflows you're creating is super helpful. And engaging us early, I think, is very important because none of us are new to healthcare. We all understand it's complex, but we all have different situations that we work in, and figuring that out. And I highlight Maryland's AHEAD model and their work towards primary care, largely because my practices are in Maryland and in Virginia. We've got 46 locations. So, half are in Virginia, half are in Maryland. We have one in DC. So I get to see the difference between the ways different states and regions are managing the complexities. And it is different. And some are stronger in some spaces and others are stronger in other spaces. But that difference, is going to create disparities of care across the country. And so trying to make that not be the case, right? Where every state wants to make sure in their state that the primary care clinicians are cared for and stay and provide services to the citizens of their state. So again, working with your primary care is really important early on in this, and primary care of all sizes, really, really critical here.
Thank you. So what I've certainly heard from all three of you is one that these changes do not happen in isolation. There's certainly some spillover effect. And with that, when states are now forced to make pretty hard and quick decisions, primary care is often where the consequence shows up. And that's often also with kids. That's often with families and with our direct practices. So I appreciate your perspectives. And to the audience, thank you for bearing with us and putting your questions in the chat. I'm going to now turn to see if how many of these that we can answer. So I'm going to offer them to you, Anne, to Perry, Sandy, and any of you, feel free to jump in to answer. First one is, what are your thoughts on integration of behavioral health into primary care for Medicaid?
Well,
yeah, go ahead, Cindy, please.
Yeah, I was just going to say, I think it makes a tremendous difference in the ability to serve your patient population. And so many of our chronic diseases, and really, obviously in young people, there's a mental health crisis. So having access to behavioral health in your clinic is incredible. It provides just a holistic version of care that we need. The brain is part of the body, so we really need to pull that together. Our healthcare system is set up so that behavioral health and medical health are siloed, physical health, they're siloed. And so lots of effort to bring those forward. There's some very successful pilots in all across the country where Medicaid programs and commercial programs as well are supporting integration of behavioral health in primary care. I think figuring out the funding model, though, is always the piece here. Value-based care is an excellent way to do that. So being able, for example, in Virginia, we have a pilot where several of the MCOs are paying an additional PMPM for different levels of behavioral health integration. So it's not just having a therapist in your office or having a collaborative care agreement, though. The primary care clinician, that person, for example, myself, I am trained more. I have done more training now so that I understand how to manage mental health, because our medical training did not emphasize that as much as it needed to. Just that's how it happened. We know that's different now, but still, you have a whole bunch of physicians out there and nurse practitioners and PAs who haven't been taught how to manage behavioral health. And so we were taught to refer, but there's nobody to refer to. And if that's the case, then you're the one now managing that patient. And so how do you then pay the primary care clinician for that extra time it takes? I can see 4 kids with ear infections in the time that I can see 1 child with anxiety, depression, suicidal ideation. So that payment of 4 ear infections is much higher than that payment for that 1 child who desperately needs my time. And so that payment differential, handling that through value-based care is one way to approach that.
Thank you. And maybe this one is for Anne and/or Carrie. How are you defining medical frailty? And are you working with your state to impact the definition?
Yeah, I'm happy to go first and then excited to hear Perry's thoughts. I think every state is in the throes of working through what is a really complicated definition. I think we've gotten some guidance initially from CMS on this front, and it continues to evolve. And so what we've done is start with the federally required definition, ANHR1, and try to fill in the gaps or the gray areas where states have a little bit of flexibility with clear diagnoses or conditions that we believe align with the intent of the medical frailty component are ones that we can easily audit or validate with our data. We actually had our first public workshop on a draft definition last week. We've gotten a lot of excellent feedback. Our draft definition already reflected some feedback we've gotten. We're giving folks about 3 weeks to really digest it and provide some more input. Once we finalize that, then we will, again, share it back with our community and ensure that we're creating resources like one-pagers or other very clear tools to help providers also understand what those requirements are and address, again, any confusion or questions that their patients may have. So our Primary Care Association is absolutely involved through the extent of our public workshop. We also are trying to hear from members themselves. So our Medicaid Advisory Council and Beneficiary Advisory Council are really key voices as we finalize this definition that works best for Nevada and is very clear to everyone who's navigating it.
Thank you. And Perry, are you all taking a similar or different approach?
I think similar. I don't think we have done the public route for folks to weigh in as much, but I think that's a good point. We can probably start doing that. We want to take as broad a definition as the federal government will allow. And not all of the guidance is out yet, but we have heard some promising things, like verbally from CMS most recently, that states are going to have more rather than less restriction of how they define medical frailty. I do think the other key piece, though, is you can have your definition of medical frailty on paper, but then it's like, how are you verifying that with data? Or what is for, people to self-report? How are we going to verify that as a state? How do we protect our state when CMS comes back and says, well, I see you gave this person a medical frailty exemption. Where's your documentation for that individual? And so defining medical frailty is really just one step. And what is actually going to be, we think, harder is operationalizing that medical frailty in a way that actually keeps people who qualify for a medically frail exemption, that gets through the system. Because we sort of talk about this like Venn diagram of people. So you have your adult group, and of that group, some folks are in school, some folks are already working. Most of them will likely qualify for a medical exemption, but then just cut that circle in half because the administrative burden is too hard for all those people to get through. So it's just sort of like so yes, we're working on it. Yes, we're comparing notes with lots of other states all the time about how to do it. And how do we operationalize it in a way that it's actually effective in capturing those who qualify?
Thank you. And in interest of time, I'm going to ask one more question. So that's a lightning round. And so I'm going to paraphrase a little bit, which is, let's say, how are state Medicaid programs, I would say, and our primary care provider practices collaborating to share communications material, IT solutions, and other interventions so that we can make this change less complex and streamlined, and so that we can reduce the loss of coverage.
I'll go first. So we, through the National Association of Medicaid Directors and just relationships, states are constantly comparing notes with each other and bringing those learnings back to the team. And then I do think there are many different, nonprofits, consultants, different kind of IT firms out there who often bring to each individual state, their expertise, but also their expertise from other states. So I will say there's the biggest restriction I find in Maryland to us collaborating and understanding from other states is just hours in the day. There are 56 Medicaid programs. You can only spend so much time comparing notes. But as Anne knows, we have all of our WhatsApp groups as like, well, what about this? Well, what about this? Oh, I didn't know you could do this. So we're constantly going back and forth. And then I do think, CMS also convenes states together to share learnings, and CMS will be collecting information and then pushing that out to states. So there is just like a Medicaid ecosystem where learnings are constantly being shared. And then it's just a matter of, do you have the resources to leverage all of that and to dive into it?
Thank you. Anne and Sandy?
Yeah, I can speak from the clinician perspective. We are organized in so many societies in so many places. The American Academy of Pediatrics, obviously for the pediatricians, AAFP for the family docs, ACIP for the internists, the ACOG for OBGYNs, and they all have state versions of their societies. So making sure they're engaged. I've been very impressed with Maryland's. Again, I'm in multiple places. So in Maryland, the AHEAD model, when that's out rolling, there's a lot of engagement of primary care in that, in the conversations and the advisory councils and such. And it's been really great to be a part of that. In Virginia, we have a primary care task force where it's a group that's all different stakeholders that have come together to focus just on how do we stand up primary care in our state. So there's versions of this in all the states. And so just again, making sure we're sitting at the table having that conversation, because ultimately you're impacting our businesses and our practices' ability to survive and our ability to take the best care of the patients. Because to us, we aren't paying attention to what insurance they have, where their families or people we've been caring for over the continuum. That's the purpose. I heard somebody say primary care is where the patient stays the same, but the diagnoses rotate over time. Whereas in a hospital, the diagnosis stays roughly the same, the patients rotate over time. And so we're taking care of individuals, and their insurance just becomes this complex thing we have to deal with to take care of them.
Thank you. Well, I see Anne Greiner has come on camera. I think she's coming on to call me in. So I do hope that you all will also remember that PCC is also an excellent resource as we think about how we could share communications, so that we can streamline information, so that we can use each other as a resource. Like to end with just know, yes, we're in the midst of complexity, but the story is not finished. What happens next will largely depend on whether states can continue to prioritize continuity, clarity, capacity, communication levels, especially in primary care, as these changes are rolling out. Thank you to our panelists. Thank you for the questions. Sorry we did not get to answer all of them. I'm trying to at least select ones that were broadly applicable, and turning it back over to you, Anne, for any housekeeping information.
Well, thanks so much, Brandon. And Brandon has helped to lead a lot of important work at the PCC focused on Medicaid and the broader safety net. And thank you to all of these terrific panelists, and each of them are primary care champions. So it's really an honor to have them join us. And I think we heard how critical primary care is in this environment of constrained resources for children and, yes, for adults, and the importance of maintaining the relationship. We want to mitigate loss of coverage, and we also want to make sure that we try to do whatever we can to mitigate burden on primary care that has to deal with a lot more requirements. So how do we our tech partners, how can you help us mitigate that additional burden? This webinar will be made available on our website within 48 hours. Please look out for the survey that will pop into your email boxes. And we're so pleased to have you join us today. The conversation will continue as we together chart these new waters. Thanks so much. Bye now.